My name is Shom Goel. I'm a medical oncologist at the Peter MacCallum Cancer Centre in Melbourne, Australia, and I'm very pleased to be moderating this morning's poster spotlight session, the topic of which is targeting the ER and PI3K pathways, novel drugs and combinations. I hope some of you have had a chance to view the posters over the last half an hour and engage in some discussions with the presenters. There's certainly some very interesting material up there covering some very timely or so-called hot topics in breast cancer at the moment. The format for today's session is that we're going to discuss the posters in two groups. So we're going to begin with the posters that cover the PI3 kinase pathway. And with that in mind, I'd like to invite the presenters of those four posters to come and join us on the stage here. So that's Dr. Saura, Dr. Juric, Dr. Jhaveri, and Dr. Sinkevicius. Thank you. And once they're up, I'll invite our discussant up to talk us through their work. All right, while people are coming up, I'll introduce our discussant for these posters. It's Dr. Chris Vaklavas from the Huntsman Cancer Institute in Salt Lake City, Utah. So please welcome Dr. Vaklavas, but we'll just get started once our presenters are all up on the stage. Thank you.
All right, for the interest of time, we're going to get started. So thank you so very much, Shom, for the kind invitation. I'm Chris Vaklavas from the Huntsman Cancer Institute, and I'm going to be discussing the PI3K inhibitors. These are my sinful relationships, and I used my own intelligence to prepare this presentation. So I would like to congratulate the authors of those very impactful abstracts and for discussing those very highly anticipated results, and thank the organizers for giving me the opportunity to discuss those abstracts. So to set the stage, this is the PI3K signaling pathway. There are multiple. The PI3K family is a very large family. There are three classes. The most pertinent, germane to breast cancer, is the PI3K alpha. It is in unstimulated cells. It is in the cytoplasm. It is heterodimer. There is the catalytic subunit, which is encoded by the PIK3CA gene, and it is in conjunction, if you will, associated with the regulatory subunit. There are 5 species of the regulatory subunit. It receives inputs by the receptor tyrosine kinases and also RAS small GTPases. So when the receptor tyrosine kinases, for example, are getting stimulated, it translocates to the cellular membrane, and it catalyzes the phosphorylation of the phosphatidylinositol diphosphate. There you go, I said it. To a triphosphate. And the PIP3 serves as a docking site, if you will, to pH-containing proteins that contain the pH domain, and then they signal downstream and regulate a series of processes. So obviously those processes are very spatiotemporally regulated in the normal cells, but they go awry in cancer cells. So this is how the catalytic subunit looks under the microscope. It has a kinase domain. The kinase domain actually has 2 subdomains. They are connected with a hinge, and this is where the ATP binds. So mutations in the PI3K occur across the gene. There are 2 hotspot mutations. One is the disruptor mutation that occurs in the helical domain and disrupts the association of the catalytic subunit with the regulatory subunit. And the other mutation is hotspot, if you will, is in the C-terminus of the protein, and it's called binder mutation because it enhances the association of the catalytic subunit with the cellular membrane. So there's the histidine in the 1047 position that it is being replaced by arginine and other amino acids, and the arginine is positively charged and increases the association with the cellular membrane. So cancer biology does not do us a favor for the mutations to happen at the kinase domain. So the orthosteric ATP competitive inhibitors have a very hard time to differentiate between the wild type and the mutated PI3K, just because conformationally the kinase domain is not perturbed substantially when we have those hotspot mutations. So believe it or not, we had known about the PI3K since the 1985, the retroviral oncogene era. But it has been nothing but crossing the valley of death to develop drugs. So the drugs in development have come in waves. The overarching theme is that there has been an increasing specificity starting from those wortmannin and other tool compounds that blocked irrespectively multiple members of the family, all the way to the alpelisib, which is the isoform specific. It blocks the alpha isoform, and now the new kids on the block, mutant selective isoform specific, and there's another new kid on the block, the PI3K alpha RAS breaker. So more on this a little bit later. So alongside with Forrest Gump over here, there has been alpelisib and inavolisib that crossed this valley of death. Alpelisib never really kind of gained the acceptance or the favoritism of the oncologist, and inavolisib bringing the added property of being a degrader. So we do not know how these properties pharmacologically conferred. Inavolisib is very related to tazelisib, the predecessor, which reached phase 3 clinical trials, but never kind of reached approval. So there may be some selectivity on inavolisib by virtue of the activated catalytic subunit being better poised, if you will, to undergo ubiquitination. And so there may be kind of the degraded preferentially. So what is the biggest liability of those drugs? The biggest liability is the on-target off-tumor effects. When you throw into the system a non-selective PI3K inhibitor, yes, we're going to give the cancer cells a bloody nose, but at the same time, we wreak havoc to the glucose metabolisms by interfering with the insulin signaling. So there are surges in the glucose, which in turn cause surges in the insulin, and insulin actually blunts the anti-tumor effect of the PI3K inhibitor. So a mutant-selective isoform-specific inhibitor, the promise is that it abrogates, mitigates all those metabolic effects, unfolds the true potential of blocking a PI3K pathway, and avoids those compensatory hyperinsulinemias that may blunt the anti-tumor effect. So the very first idea that there is an allosteric pocket that we could actually engage and block the PI3K comes back in 2012. So it was Dr. Williams who was working on a PI3K beta inhibitor. This is the tool compound that they were using, the PIC108. And as they were doing crystal structures, they found out that this tool compound co-crystalled both in the orthosteric and the allosteric site. So later studies have shown that when the PI3K acquires this kinase domain, the C and the mutation in the C terminus, the C terminal tail becomes very, very wiggly and unveils this allosteric pocket. So this allosteric pocket can be accessed and targeted pharmacologically. So as a matter of fact, if you cut the C terminus of both the wild type and the mutated PI3K, actually this pocket is equally accessible. So these are the compounds, how they look under the microscope with the scorpion 478, relay 2608, and the LOXO 783. The scorpion, the relay bind in the same allosteric pocket. We do not know where the LOXO 783 binds. So very elegant studies have shown that at least with those isoform-specific mutant selective, we do not have hyperglycemia. For the interest of time, I'll show the schema of the LOXO 783. All studies actually followed the very similar schemas with the dose escalation followed by a dose expansion. I should applaud the Scorpion for investigating their medicine in head and neck cancer. This is an orphan entity. We have to remind ourselves these people are still stuck with a 50-year-old cisplatin, so we need to make a dent in this disease as well. So hyperglycemia, the moment of truth. So very elegant models have shown no hyperglycemia in mice. In these early phase clinical studies, we see that indeed those isoform selective mutant-specific inhibitors do not cause big surges, at least in the glucose levels. You can actually appreciate that there is a little bit of greater surges in glucose with the Relay 2608 at the higher doses, but those doses are not going to be pursued any further. If anything, lower doses are being pursued. Now, there's a big footnote, if you will. Here are some devilish details over here that all clinical studies have excluded patients whose glucose levels were not within a normal range, or the hemoglobin A1C was not lower than 7. The LOXO 783 has a separate cohort with patients with diabetes, but the diabetes has to be very vigorously controlled, if you will. So the moment of truth number 2, we have carved out the hyperglycemia, although not completely. I should acknowledge probably there is very intense monitoring in these clinical trials to make sure that the sugar levels stay within range. But there's still some on-target off-tumor effects, hyperglycemia, rash, diarrhea, nausea and vomiting. There you go. And especially diarrhea with the LOXO 783, which actually kind of hampered the development of the LOXO 783. Tacitly, the development is not going to be pursued any further. And there are some drug-specific, if you will, adverse events, including the AST-ALT elevations with the Scorpion 783. 478, and headache and hypokalemia with the Relay 2608. When I look at those tables, I always pay attention to dose reductions, dose holds, and interruptions. It's not a singular, if you will, grade 3 toxicity that will prompt Ms. Smith to come off a medicine. Usually Ms. Smith is going to beg us to come off the medicine by a grade 1 fatigue, compounded with grade 1 nausea, compounded with grade 2 diarrhea. All of those adverse events cumulatively prompt Ms. Smith to come off the medicine or have a dose reduction or even withhold the drug. So in terms of efficacy, I'm showing here the Scorpion 478 and the LOXO 783. There are, in the upper panel, is the reductions in the variant allele frequency of the PI3K. Very, very interestingly, we can see that there are reductions both in the PI3K with the kinase mutation as well as with the mutation in the helical domain. And this is very, very interesting because all of those drugs have been developed with the 1047 mutation in mind, but apparently engaging this allosteric pocket causes some major perturbations in the catalytic subunit. So in terms of efficacy, the overall response rate with the Scorpion 478 is 22%, disease control rate 68%, overall response rate with the LOXO 783 was only 6%, but disease control rate, it was at the acceptable 52%. Those drugs, I'm afraid, do not work on their own. They have to be combined with endocrine therapy. So as monotherapy, we haven't seen significant response rates. So focusing a little bit further on the Relay 2608, since it has the more mature results, again, we see very nice reductions in the variant allele frequency of the PI3K, which for the time being, I'll take it as a pharmacodynamic marker. The drug is doing what it's supposed to do. Both with mutations in the helical domain and the catalytic and the C-terminus, the 1047. What was extremely interesting to see was the decline in the variant allele frequency of the mutated estrogen receptor, especially, I'm going to be challenging your vision over here at the Y537 mutations, which are totally insensitive to the fulvestrant. So I would assume that this is an indirect effect of the medicine, probably decreasing the transcription of the mutant ESR1. And a glimpse of what to expect, if you will, as these drugs moves forward in terms of progression-free survival. They reported 9.2 months, which may be a little bit higher if we use it strictly as a second-line therapy. So last but not least, there's a new kid on the block. There's this PI3K alpha RAS breakers. The way that they work is they covalently engage cysteine 242 in the RAS binding domain of the catalytic subunit, and they abrogate inputs from the RAS GDPases to the PI3K pathway. Very elegant models as well. Cell-derived xenografts have shown synergism and very nice tumor reductions in the triple-positive breast models, as well as hormone receptor-positive HER2-negative models. I tried quite a bit to kind of wrap my head a little bit around those results because and kind of explain a little bit the activity of this drug on the mutated PI3K. And I have two explanations. One possible explanation is that the engagement of the cysteine 242 probably causes more widespread perturbations in the catalytic subunit. And the second explanation is that, especially kind of focusing over here in the HER2-negative models, you would expect a very good synergism in the HER2-positive because the HER2-amplified models, the HER2 engages the RAS small GTPases. But in the HER2-negative, probably we have overexpression of receptor tyrosine kinases like the HER2, the FGFR, and they may not, for example, the HER2 may not reach the 3+ immunohistochemistry criterion, but the 1+, 2+ is doing business, and we can actually abrogate that with this breaker. So are allosteric PI3K alpha inhibitors a step forward? I think there is a unanimous yes over here. That gives us the opportunity to unfold the true potential of blocking this pathway. But there are about a dozen footnotes over here, so bear with me. So yes, we can hit the target harder, and we can use this drug in combinations, but there are cumulative low-grade toxicities that may lead to dose reductions, interruptions, and delays, and that kind of, if you will, may compromise the target engagement. The PI3K pathway can be activated by mechanisms other than PI3K mutations. There is upregulation at the translational level. The PI3K mutations are heterozygous, and tumor cells may depend on both the wild type and the mutant PI3K. So when you block the mutant PI3K, you leave the wild type PI3K unchecked, so the cancer cells may rely on the, put all their stock on the wild type PI3K and continue growing. So activity across the PIK3CA mutations is unknown. And will hyperglycemia still be low in broader patient populations? And where kind of we follow those sugar-loaded, Americanized or American diets? We do not know that. And the onset of activity may be slow as the catalytic subunit dances around the different conformations. It has to unveil this pocket for those isoform-specific mutant-selective PI3K inhibitors to bind. So thank you so very much for your attention.
Thank you. Thank you very much, Dr. Vaklavas, for summarizing these 4 studies so well. We now have some time for discussion, and we'll start by opening up for questions both for people online and people in the room. Do we have any questions from the audience? Well, while people are thinking of questions, I might get this discussion started. And I'd like to pick up on the point that is still up, was on Dr. Vaklavas' last slide about this concept of mutant selectivity when you inhibit PI3 kinase being a vice or a merit. Because, you know, and I need to be educated here, so I'm going to ask the people who know next to me. If we think about a lot of these tumors maybe having one allele of mutant PI3K, one allele of wild-type PI3K, and believe that the wild-type PI3K may be having an important role in driving tumor growth. I'd like to hear from all members of the panel what their thoughts are on the risks of dialing mutant selectivity up too much. Maybe we'll just, whoever wants to start.
Shom, thanks for the question. Let me just, without any doubt, say this. Development of mutant selective PI3 kinase inhibitors, it's a holy grail for the field. I've been involved in development of non-selective and then isoform-selective inhibitors. We simply cannot hit the target hard enough. With mutant selective inhibitor, we have a chance to hit the target hard. We have a chance to avoid hyperglycemia, which patients do not like, no matter how beautiful the biology is. And then because of improved therapeutic index, higher pathway inhibition, these agents are fantastic combination partners to deal with precisely these redundancies that we're talking about. Now, you're asking about this one particular issue, which could wild-type alpha gets activated. It could, both through adaptive mechanisms and hardwired changes such as P10 alterations, which also result in PI3 kinase beta. So yes, I think single-agent approach, even with these agents, is potentially problematic. And to prevent these adaptive and acquired resistant mechanisms, we will need, at minimum, fulvestrant combination or other SERD combinations, and then higher-order combinations. I think that's the next frontier, these higher-order combinations.
Thanks, Dr. Jhaveri.
Thank you. And I think I would just piggyback on what Dr. Juric was mentioning. I think, the one thing that we know is you can only derive benefit from a medication that you're able to tolerate and take for a longer time. That's one. And two, the safety profile that we're now beginning to see in these newer generation mutant selective inhibitors makes them appealing not only to hit the target and avoid the toxicities that we've seen with the prior inhibitors that are approved, but also offers this opportunity to go beyond the doublet regimen to even triplet regimens to further do comprehensive blockades. And because of that safety profile, we might be able to see that maybe even with those triplet regimens, which are now being entertained in clinic and have shown more synergy and more additive activity, that we might be able to achieve that. Whether that wild type will take over, it doesn't seem, at least in the early signals. Certainly we have to pass the stress test in larger randomized cohorts to be able to appreciate that better. But at least the idea behind avoiding the wild type with these mutant selective inhibitors to avoid the toxicities we were challenged with in clinic for our patients has certainly been addressed, seems like, in the phase 1 trials. And we're looking forward to seeing the larger randomized cohorts to appreciate that better.
Thank you so much. Other members of the panel?
Yes, I can only echo the things that it has been said. I think the safety profile of these drugs, it's really making the difference. And again, we learned through those years that it has been showed in the discussion that we really need to have a drug that is tolerated and should be combined with other drugs to perhaps target those mechanisms of resistance. So no monotherapy.
Yeah, so I think this is a question we can probably address and ask and get an answer to in the clinic with our breaker compound. So our breaker compound stops the interaction of RAS-driven PI3 kinase alpha, as the discussant said. And so we block wild-type and mutant signaling. Now, it's not a kinase domain inhibitor. It's a novel mechanism of action. So insulin can still bind to the receptor in normal cells, even when breaker is there. It's RAS-independent. So we don't see any hyperglycemia and should be very well tolerated. So in combination setting, you can imagine you could have an upregulation of wild-type PI3 kinase signaling, and our breaker would be able to perhaps block that. So we'll be able to test that in the clinic.
Thank you. If I may just add one thing, just looking at the data with STX478, what was really interesting to me, you had roughly 41% of patients with prior PI3 kinase inhibitor exposure. So this is really, you're stacking the deck against yourself. And despite that, you see the activity. You have almost half the patients who are pre-diabetic or diabetic. So again, you're stacking the deck against yourself. You're really pushing it. But still, the drug is tolerable even in that setting. So I mean, this tells you that, choosing mutant selective approach really is a compelling concept.
Thank you. And I guess, I'll just check again if we have any questions. Oh, we have a few coming in online. So some of these questions now are getting quite specific to the individual compound, so I might just run through those. People are interested in some specifics. The first one is for you, Dr. Saura. It's about RLY 2608. What is the significance of the increase in is it creatine or creatinine kinase that was observed? Could you talk to us about that? And is it important? And also, if you could comment on the level of grade 3 fatigue that was observed in the study.
Okay, thank you for these questions. Regarding the levels of creatinine that it has been seen, that it's around 30% of the population, mainly grade 1 or 2. It's something that we've been seeing through the dose escalation and also at recommended phase 2 dose. We don't have a clear explanation on that. We think it's multifactorial, and we are yet trying to understand what's happening there, but no clear explanation.
Thank you. Thanks very much. One for Dr. Juric.
Sorry, and regarding the fatigue.
Oh, sorry, yes, the fatigue.
Yeah, the second question. I think that it's quite difficult because those patients are quite pretreated, sometimes to differentiate or to say that the fatigue is related to the drug. I could say that in the clinic, it's not something very common, and mainly grade 1 or 2, difficult to relate with the drug in patients with metastatic cancer.
Thank you. One for Dr. Juric regarding STX-478. The report of some DLTs of grade 3 myalgia, grade 3 paresthesia that was made. Do you think that this is an on or off target effect?
That's an excellent question. This obviously happened at the highest dose tested, 160 milligrams. It was a very brief, but quite, to a patient, uncomfortable event with complete resolution of symptoms. Is it on target, off target? We don't fully know. We're pushing the exposures of this drug to much higher levels than what we've seen with other inhibitors, such as alpelisib and alpelisib. Is it possible that in some ways is related to such a high levels of PI3 kinase pathway inhibition, which has a widespread role in many cells? Or is it some sort of unique effect that happens only when we exceed maximum tolerated dose? To be very frank, we don't know. We do know that maximum tolerated dose of the drug is 100 milligrams, and we do not see these issues at those doses or below.
Thank you. I have a question now for Dr. Jhaveri regarding the LOXO compound. The question says, this compound seems to be less efficacious. Can you comment on this and any reasons you think that might underlie this observation?
Thank you so much for this question. I think, when we were looking at the data for all the doses and all the dose levels that were tested, while we did see that there was a decrease in the EC90 for proliferation, the target exposures were limited and were achieved for EC90 for phospho-AKT only at the 600 milligram BID dose in combination with fulvestrant. We were not able to achieve that with monotherapy, and we were not able to dose escalate beyond the 600 milligram BID dosing due to the toxicities. We saw 2 DLTs at that dose level. And so while we did not formally announce an MTD, we think that the 400 BID dose was there, but the target exposure was only achieved with a doublet. So the challenge here is not being able to achieve the target exposure, which was limited by the toxicity, predominantly diarrhea. And so I think that has potentially contributed to the lack of the activity or the modest activity that we've been able to see with this compound. There is a next generation compound, the 5004 LY. The preclinical characterization is shared as a poster at this meeting. And the hope is that potentially this will have better ADME properties as a drug and potentially will not be limited the way we were with LOXO-783 to only the only the kinase domain mutation of 1047R, but beyond that to the helical kinase domain mutants as well. And so we'll see what that compound has to offer.
Thank you so much. One more chance for questions from the audience in the room. Otherwise, I've got plenty more. All right. I'd like to ask a question to you, Dr. Sinkevicius, about this very interesting mechanism of this PI3K RAS breaker. I can see in the preclinical work you've been looking at both models of ER-positive, HER2-positive disease as well as ER-positive, HER2-negative disease. And Dr. Vaklavas sort of outlined some of the reasons why targeting the HER2-positives might make particular sense. But I'm wondering your thoughts on that, and also, as you see this compound entering the clinic, are there particular subgroups of breast cancer that you think are the most relevant or appealing?
Yeah, so I think it's been one of the fun parts of this program. It's a novel mechanism of action and figuring out where to go first. In vitro, we see the highest activity in the HER2-positive space. So in the clinic, we will be going into doing the trastuzumab combination first in the breast cancer patients. But beyond that, we can also, in breast cancer, in the preclinical models, really strong data in combination with fulvestrant and ribociclib, regardless of the PI3 kinase alpha mutation. And again, if wild-type PI3 kinase as a resistance mechanism, we might have an advantage there as well. Beyond that, beyond breast cancer, we also see great activity in the KRAS mutant space. So you can imagine we can combine this with chemo in colorectal cancer and with G12C inhibitors in lung and other spaces as well. So there's a lot of potential for this molecule and should be well tolerated in combination since we shouldn't see hyperglycemia.
Great, thank you. And I think one question that's coming through repeatedly, and I think it's a good sort of educational point for us. If any of you can comment in the ER-positive cancers where there is an activating mutation in PIK3CA, how common is it to see co-occurring alterations in the pathway, be that AKT or PTEN? And if they're seen, what would your prediction be regarding the impact on the efficacy of these mutant-specific inhibitors? And yeah, maybe Dr. Saura can start because you sort of discussed this a little in your abstract.
Yes, I think that this is something definitely important, taking into account that the PI3K is upstream of the PTEN and AKT mutations. In the development of Relay, for example, we've seen that those patients with downstream alterations, PTEN or AKT, the efficacy does not seem to be the same for these compounds, and this is important. And for that reason, in the phase 3 that it's planned for the next year, we will exclude those patients. So it's nice to see that the pathway makes a difference in the clinic, and we can select more and more the patients that could derive benefit, taking into account the type of drug. So, for example, it won't be the same to use capivasertib or other drugs more selective for those patients, depending on the alteration of the pathway.
Thank you. I'll give anyone else on the panel an opportunity to comment, and then we might move on.
I think this is a fantastic moment to say the precision oncology paradigm, it's not just about giving the right treatment to the right patient. There is one more component there, doing it at the right time, okay? So as you get exposed to treatments before your intervention with the mutant-selective agents, you are actually risking accumulation of multiple concomitant alterations. We should not forget that, for example, PTEN loss is a cross-resistance mechanism for CDK4/6 and PI3 kinase alpha. So if you have upfront exposure to PI3 kinase, to CDK4/6 inhibitors, all of a sudden, otherwise low rate of PTEN alterations goes up. So now you have a potential problem in the second-line setting. That's why you then need proper combinations even in that context, or you move the drug up. And this is where selectivity and therapeutic index matter. To give a frontline treatment, you need to have really clean drugs. The patients need to stay on it for years. And I think the opportunity here is to exploit these early phases of the treatment, not let the patient is exposed to multiple treatments and they then increase the genomic complexity of these tumors, because that will be a problem. So I think the timing of intervention will matter, and it's likely that in the early lines of therapy, you may have a simpler genomic landscape where your intervention may have the highest benefit.
Thank you. I'm sorry that we're out of time, apologies, but I'd like to ask you to join me in thanking all of our presenters and also Dr. Vaklavas for an excellent discussion. We'll now move on to the second half of this session. So we're switching gears a little bit now, and we're going to be talking about targeting ER. And in particular 4 posters that address questions relating to some of the novel selective estrogen receptor degraders. So I'd like to invite the poster presenters to join me here up on stage. That's Dr. Lloyd, Dr. Rugo, who's actually presenting 2 of the posters, and Dr. Baird. Thank you. welcome up. Please take a seat. And I'd like to introduce our discussant for these abstracts, Dr. Rinath Jeselsohn from the Dana-Farber Cancer Institute in Boston. Thank you.
Thank you, and thanks for the organizers for the opportunity to present these great abstracts, and to the all the authors of this wonderful work. So these are my disclosures. So these are the 4 abstracts I'm going to discuss. The first abstract is an abstract on real-world data on elacestrant. The second and third abstracts are elacestrant combinations, and the last abstract is on a combination of camizestrant and ribociclib. So to start, as a brief introduction, endocrine resistance can be categorized in general to 2 large categories. One is an ER-dependent mechanisms of endocrine resistance, and then ER-independent. And then when we think about ER-dependent mechanisms, there are multiple mechanisms. However, one of the key genetic mechanisms of acquired ER-dependent endocrine resistance are the ESR1 ligand binding domain mutations. And these mutations have now been very well studied. Their structure has been solved. We know they lead to constitutive ligand-independent activity, meaning resistance to aromatase inhibitors. They also lead to decreased tamoxifen affinity and decreased potency of tamoxifen, as well as decreased fulvestrant affinity and estradiol affinity as well. So what do we know about resistance to fulvestrant in the setting of the ESR1 mutations? We now have data, retrospective data from a number of studies supporting resistance to fulvestrant in the setting of the ESR1 mutations, or at least relative resistance to fulvestrant. So this is a retrospective analysis from the Paloma-3 trial, looking only at the arm of patients who received fulvestrant alone. And in subgroup analysis of these patients, when you compare patients with wild-type ER versus patients with mutant ER, you can see clearly that patients with a mutant ER did worse with fulvestrant alone. We also have data from the Monarch-2 trial. This is also a retrospective analysis looking at the different arms and the ER mutations. And here you can see that when you look specifically at patients who received fulvestrant, and specifically at the Y537S mutation, you can see that patients with the mutation, their PFS was 4.8 months versus patients with wild-type ESR1, their PFS on fulvestrant alone was 11.2 months, clearly a difference in PFS. So we also know that the ESR1 mutations are rare in primary disease. They're found in up to around 3% of patients with primary disease, and we start to see them in metastatic disease, and where we really see that they're prevalent is in metastatic disease after at least 1 line of endocrine therapy, as you can see here in this chart. And really in metastatic ER-positive breast cancer, we can find them in up to about 60% of patients after first line of endocrine therapy in metastatic disease. That's important to note that not all ESR1 mutations are the same, so they differ in their ligand-independent activity and also in their resistance to ER antagonism. And as you can see here in this table, really the Y537S in preclinical studies have been shown to be the most potent, both from the the ligand-independent activity as well as resistance to antagonism. So a number of years ago, we started to think about how can we target these ESR1 mutations, since they're a key driver of resistance, and we've also shown that they're a key driver of metastases. And looking here at the ER axis, you can see there are many ways you could potentially target the ER mutations, such as inhibiting ER phosphorylation, inhibiting the crosstalk between the receptor tyrosine kinase pathways and ER. And this goes along with some of the discussion before on PI3 kinase inhibitors, as well as potentially targeting some of the key transcription targets of ER, or targeting the transcription of ER itself. But one of the most direct ways to target ER mutations is by targeting the ER mutation itself by endocrine therapies, and potentially with better PKs, and also with improved affinity to the mutant ER. So indeed, we now have several novel endocrine therapies with that are oral and have better pharmacokinetics, and we're seeing that also have better antagonism in the setting of the ESR1 mutation. And you can see these different endocrine therapies really differ in their level of ER degradation versus their level of antagonistic activity. Right now, the first and the only oral endocrine therapy, novel endocrine therapy that has been approved is elacestrant. And what do we know about elacestrant? So elacestrant was first presented actually in 2007 at a meeting where it was shown to be an agonist. However, only about in 2015, Donald McDonald's group showed that actually it has antagonistic activity and it has SERD activity. And now we know that it has a unique pharmacology where at low levels it can have some agonistic activity, but at higher levels it is an antagonist. After 2015, there have been several studies, preclinical studies, showing nicely that it has nice activity in preclinical models of endocrine resistance, including models of the ESR1 mutation. The phase 1 study was published in 2021, and shortly after, the phase 3 EMERALD trial was published in 2022, and that eventually led to the approval of elacestrant for ER-positive, HER2-negative, ESR1 mutant breast cancer after at least one line of endocrine therapy in the metastatic setting. So the EMERALD trial, as I said, was a phase 3 trial in which patients who've had progression on first-line endocrine therapy and had a CDK4/6 inhibitor were randomized to either elacestrant alone or to investigators' choice of endocrine therapy. And this study had two co-primary endpoints. It was PFS in all patients and PFS in patients with ESR1 mutations. And looking at the PFS in all patients, you can see that there was a significant difference. However, clinically, this difference was not that meaningful. However, if you look at patients with an ESR1 mutation, the difference was more profound. And you can see that at 6 months, patients who were on elacestrant had disease stability, and 40% of the patients had disease stability, whereas patients with standard of care, this disease stability was seen in only about 20% of patients. So this was a positive result, and however, it's important to see that there were several subtypes of patients. There were the patients, as you can see here in this long tail, that really do benefit from a single agent endocrine therapy who have an ESR1 mutation, whereas even patients with an ESR1 mutation, you can see that about 40% of patients had a really rapid progression. It's really important for us to start to understand who are these patients that really can benefit from a single agent endocrine therapy, whereas who are the patients that need something else. And this brings me to the first poster, which is was a real-world study of ESR1 of treatment with elacestrant in patients with ESR1 mutations. So the aim of this study was to examine the real-world use of elacestrant and examine the impact on prior treatments, the type or number of ESR1 mutations, and co-occurring PI3 kinase pathway alterations on the clinical outcomes in patients treated with elacestrant. So just as a brief introduction about real-world data, so very interestingly, over the past 10 years, you can see that there's been a dramatic increase in real-world studies. And as many things in life, real-world studies have pros and cons. So some of the limitations of real-world data is that there are clearly inconsistent data from medical records or claims. There can be confounding biases, and also there's typically lack of comprehensive data on response or clinical benefit. But on the other hand, real-world data can include broader patient populations and many times populations that are not included in clinical trials. And also, obviously, it utilizes existing data for both cost efficiency and timely data. So in this study, the patients the patients were identified through the Guardant-Inform database. Patients had to have an ESR1 mutation detected by ctDNA within 6 months prior to starting elacestrant and treated with elacestrant after the FDA approval of elacestrant in January 2023. The real-world time to treatment discontinuation, or TDD, and time to next treatment, TTNT, were used as the proxy for outcomes for the PFS, and overall survival was also estimated. And overall, using these inclusion criteria, this study included 756 patients. So briefly looking at who the patients were, I just want to highlight that most of the patients received endocrine therapy prior to elacestrant. Also, a majority of patients had received prior treatment with a CDK4/6 inhibitor. And interestingly, also 41% of patients received chemotherapy prior to elacestrant. And these are the ESR1 mutations that were identified, very similar to what we're seeing in most studies, with the most common being the D538G and the Y537S mutations. So looking at time to treatment discontinuation and time to next treatment. So time to next treatment was 6.4 months in the entire population, and time to treatment discontinuation was 4.6 months. Now looking at some of the subgroup analysis. So if we look at the subgroups based on time number of lines of therapy, looking at giving elacestrant as a fourth line versus second line, or third line versus second line. As you can see here, there were no differences in both time to treatment discontinuation or time to next treatment. Looking at prior exposure to fulvestrant, also there was no difference in time to next treatment or time to treatment discontinuation. Likewise, when looking at the subgroup of patients who had a Y537S mutation versus all other ESR1 mutations, no difference in outcomes. However, when looking at patients who have a mutation in the PI3 kinase pathway, which was either mutations in PIK3CA, AKT, or PTEN, we do see a difference in outcomes. Patients who had one of these mutations, their time to next treatment was 5.2 months versus patients who did not have one of these mutations, time to next treatment was 8 months. So what are the take-home messages from this abstract? A real-world analysis of patients with advanced hormone receptor-positive breast cancer with ESR1 mutations identified more than 700 patients treated with elacestrant since the approval with very specific criteria. The time to treatment discontinuation and time to next treatment were overall in the range or slightly higher compared to PFS seen in the EMERALD trial. And most of the patients received elacestrant beyond second line of treatment for metastatic disease. And this may be because of the relatively recent approval of the drug, but it's important to note that even though patients received it at fourth line and beyond that, there was no difference in outcomes for those patients. However, patients with alterations with the PIK3CA in the PI3 kinase pathway did have worse outcomes. And this really underscores the need for precision medicine and also for combination treatments in specific patient subgroups. And this really brings me to the next abstract, which is an abstract of early data from the ELEVATE trial, which was an umbrella study looking at elacestrant with different combinations in patients with metastatic ER-positive breast cancer. So this is a phase 1b, phase 2 trial. The phase 1b component includes elacestrant with different doses and different doses of both alpelisib, everolimus, ribociclib, and capivasertib. Of note, we'll talk about the ELECTRA trial, which has the dose escalation component of elacestrant and abemaciclib. So the primary objective of the phase 1b component of this trial is to determine the recommended phase 2 doses for these combinations. And then the phase 2 expansion arms are looking at these combinations with the recommended phase 2 dose with the primary endpoint of PFS. So this abstract is the updated safety data for the various elacestrant combinations. So looking briefly at the patient population, just to highlight a few points, most of the patients in these cohorts had visceral disease. most of the patients, about 40%, 30 to 40% of the patients had ESR1 mutations. And now looking at the adverse events in the combination of elacestrant and abemaciclib, and the recommended phase 2 dose of this combination has been established. So this is looking at side effects, at the adverse events in the recommended phase 2 dose. And as you can see here, really looking at, sorry, I'll go back. Sorry. As you can see here, you can see that the side effects that we're seeing with the combination of elacestrant and abemaciclib are very similar to the side effects we're seeing with abemaciclib and standard of care endocrine therapy. And then looking at elacestrant and everolimus, also using the recommended phase 2 dose that has also been established, and this is a relatively large cohort of patients. Again, we're seeing that overall the side effects that we see with this combination are very similar to the side effects that we see with everolimus and standard of care endocrine therapy. The recommended phase 2 dose of elacestrant and palbociclib has also been established. However, a relatively small number have been on this recommended phase 2 dose, but with this small numbers, we do again see that there are no new adverse events, and the adverse events with this combination is very similar to palbociclib with standard of care endocrine therapy. Shown here in the tables to your left are the side effects, the side effect profiles from the combinations of elacestrant and ribociclib, elacestrant and capivasertib, and elacestrant and alpelisib. Again, small numbers, and these are still in the dose escalation phases of the trial, but so far there are no signals of any new side effects. So what are the take-home messages from this abstract? So overall, the recommended phase 2 doses of elacestrant in combination with abemaciclib, everolimus, and palbociclib have been established, and the safety profile looks very similar to what we see with these drugs with standard of care endocrine therapy. The combinations of elacestrant, the recommended phase 2 doses of elacestrant and ribociclib, capivasertib, and alpelisib are still not established yet. So far, the data looks promising, and these studies are still ongoing. So the ELEVATE trial is still a little early, and we do not have efficacy data from the ELEVATE trial in this abstract. However, this is a good segue to the next abstract, which does give us some early efficacy data with the combination of elacestrant plus abemaciclib. So in this abstract is a pooled analysis from the ELECTRA phase 1b trial, which was designed to establish the recommended phase 2 dose of elacestrant and abemaciclib, together with the arm C of the ELEVATE trial that I just showed you, which was the arm looking at the combination of elacestrant and abemaciclib, looking both at both cohorts that were the cohorts that received the recommended phase 2 dose. So I don't know why I'm having trouble with this. Let's see here. Okay, sorry. All right, so looking at some of the patient characteristics, as you can see here, most of the patients had visceral disease. All patients had received prior treatment with a CDK4/6 inhibitor, and about 30 to 50% of patients had an ESR1 mutation. And then as far as the side effects, very similar to what I've shown you from the previous abstract, when we pool both patient populations together, both cohorts together, looking at the recommended phase 2 dose, again, no new signals of toxicity. And then this is the early efficacy result, so looking at clinical benefit rate, so looking at the patients that received the recommended phase 2 dose in both, from both studies, we can see that there really was a significant clinical benefit rate of 84%. But again, this is early data. And then when we look at patients from the Electra trial that had valuable disease, we see that the PFS for these patients is 8.7 months. And interestingly, if we look at a subgroup of patients from this cohort, that the patients that had more than 12 months of stability with a CDK4/6 inhibitor and endocrine therapy prior to elacestrant, the PFS in elacestrant plus abemaciclib was 16.6 months. So a very impressive number, but still early data. So some of the take-home messages are that the safety profile in this larger cohort with the recommended phase 2 doses of elacestrant and abemaciclib is consistent with the safety profile of abemaciclib with standard of care endocrine therapy. These are early results from a relatively small patient population, but the results from the Electra phase 1b trial of efficacy look very promising, and we'll await to hear of the more mature results. So the next abstract is on a different SERD, and this is an abstract on camizestrant. What do we know about camizestrant from the published data? So there are several preclinical studies looking at the activity of camizestrant in both the ESR1 mutation models as well as other models of endocrine resistance and combinations. The SERENA-1 trial established the phase 2 dose, which now, and as well as this SERENA-1 trial is a trial that's still ongoing, looking at different combinations, which is the combination of part KL, the combination of camizestrant and ribociclib. I will show you data in the next few slides. And then SERENA-2 is the phase 2 study comparing camizestrant 75 milligrams 100 or 150 milligrams to fulvestrant, and that was recently published. So this is the abstract, and the primary objective of this abstract is to determine the safety and tolerability of camizestrant in combination with ribociclib, and also secondary objectives were to determine the anti-tumor activity, efficacy, and pharmacokinetics of this combination. So these patients in these trials were allowed to have up to 2 lines of chemotherapy. There was no limit of endocrine therapy, and they were allowed to have CDK4/6 inhibitors or prior treatment with fulvestrant. This study looked at 2 different doses of camizestrant, 400 milligrams and 600 milligrams, with a dose of 75 milligrams of, 2 doses of ribociclib, 400 milligrams and 600 milligrams, and camizestrant, 75 milligrams. So looking at patient characteristics, very similar to the other studies, visceral disease in most patients received prior treatment with a CDK4/6 inhibitor, and then also somewhere between 40 to 60% of patients had an ESR1 mutation in this study. And adverse events, so again, we're seeing some of the adverse events that we've seen in some of the prior studies, including different ocular side effects that are mostly grade 1-2, and from other studies we know they are reversible, as well as sinus bradycardia. As far as pharmacokinetics, there was no signal of any changes in the levels of ribociclib, both for the 400 or 600 milligrams when we combine it with camizestrant, and the exposure of camizestrant 75 milligrams when we combine it with 400 or 600 milligrams was comparable to published population PK simulations of camizestrant 150 milligrams. As far as efficacy, clinical benefit rate was above 50%, in both doses of ribociclib, and then median progression-free survival was also an impressive number of 8.1 months in both arms, including the 400 and 600 milligram doses of ribociclib. And they also saw nicely a decrease in ctDNA variant allele frequency of ESR1 mutations already after one cycle of ribociclib. So some of the take-home messages, ribociclib steady-state exposure is not affected by camizestrant. Camizestrant of exposure to 75 milligrams together with ribociclib is comparable to 150 milligrams, which we know is also a safe dose. The combination is overall well tolerated. Again, there's some unique side effects that we're seeing here again, but overall these are low grade, and there's promising efficacy with this combination. And again, we're seeing a significant reduction in the ESR1 mutation. One thing to note that this study also included a small number of premenopausal women, and it'll be interesting to hear more about those patients. So I know I'm running out of time, but just briefly, what have we learned from these posters? If we look at a workflow for treatment in metastatic disease post-CDK4/6 inhibitor in a very simplified manner. We can think of patients who have ER-dependent versus ER-independent disease. One biomarker is the ESR1 mutations. However, we still need additional tools to distinguish between these patients. And then when we think about patients with ER-independent disease, these patients probably will not benefit from additional endocrine therapy and therefore probably better served by different types of treatments such as ADCs and other treatments. Thinking about patients with ER-dependent disease, you can divide them to patients who have an ESR1 ligand binding mutation versus other mechanisms of ER-dependent disease. And when thinking about patients with an ESR1 mutation, there is an option of single agent oral SERD, and potentially really for patients who've shown disease stability or endocrine driven disease by having disease stability for more than 12 months on a CDK4/6 inhibitor and endocrine therapy and other clinical features. In addition, there's another option of oral SERDs with combinations, and we're now seeing from these posters that the combination of a SERD with abemaciclib or ribociclib is safe, and there is an activity in patients who are post-CDK4/6 inhibitors, but there are other combinations, and really it will be important to understand what are the genomics or other pathways. And then one thing I wanted to highlight here is that we're seeing from the real world data is that there are patients that have received a single agent elacestrant even as fourth line after chemotherapy, and we're still seeing activity of elacestrant. So there are patients that may benefit from endocrine therapy even in later lines. And this also points to the question if really for patients who have an ESR1 mutation, should we be continuing to treat these patients with endocrine therapy, even though we are transitioning to chemotherapy or other types of treatment, because patients who have an ESR1 mutation may be addicted to this pathway, and it would be important to continue to treat these patients with endocrine therapy, similar to the way we treat patients with anti-HER2 directed treatments in patients who have an HER2 amplification. So with this, I will end and want to thank you all.
Thank you, Dr. Jeselsohn. Now, we are a little short on time, but I do want to give our presenters the opportunity to comment on a few things, and I hope some of you have the time to stick around. If it's okay, I'll start with a question maybe both to Dr. Rugo and Dr. Baird, and it's more of a philosophical one. You know, we're seeing so many new SERDs being developed. We're thinking about combining them with a variety of CDK4/6 inhibitors, selective CDK inhibitors, PI3 kinase inhibitors, and it feels like every combination needs to be tested because there are genuine safety issues that could emerge when combining two novel drugs. In that landscape, the combinations and permutations of doublets and triplets is hard to wrap one's head around. So I'm wondering if you have any general thoughts on how we should approach this problem moving forward. You know, Dr. Rugo, your experience combining elacestrant with a variety of different partners may have given you a chance to think about this. I'm just curious if you have any thoughts about the best way we should be approaching this complexity moving forward.
It's a great question, and I think a very important one for us. We have a whole host of new endocrine agents. They all seem to be effective. We're waiting for phase 3 data on many of them, and we'll see the data from EMBER-3 today. And then we want to combine them with all of our targeted agents. We also, as we saw in the first session, have an increasing number of targeted agents. We can't do a phase 3 trial with every single endocrine therapy and every single targeted agent. So I think we're going to need some proof of concept idea that if you can do the phase 1 and show it's phase 1b, it's safe, you have an expansion, you show efficacy, that you can actually carry that over from previous data where the targeted agent was initially approved. You need to know that pharmacokinetic and drug-drug interaction issue. But once you've done it, I think we're going to have to think about it, whether we can approach a new pathway to using these drugs and for regulatory approval, because there is no way to do it otherwise.
That's a really interesting comment and a concept. Dr. Baird, do you have anything to add to that?
Yeah, I think I would agree with that, and I think it just shows the importance in the way that we design our phase 1 and 1b combination studies, that actually we do explore these things in great detail with sufficiently sized cohorts to be able to make those conclusions.
Thank you. And I might ask a question to Dr. Lloyd as well. I was interested, Dr. Jeselsohn showed us in our presentation that not all ESR1 mutations are the same, both in terms of the degree to which they confer ligand independence and also that relative resistance to sort of standard endocrine agents. In your analysis, you saw a variety of cases which had 1, 2, 3, 4, or even more than 4 different ESR1 mutations within the same tumor from one patient. So first of all, I'm wondering, and forgive me if this is already known, but can you tell us anything about the activity of elacestrant against those different ESR1 mutants? Is there any differential activity at all? And do we know anything about the biology of polyclonal ESR mutant breast cancers compared to those with a single mutant?
Thank you so much for the question. I think it's a really important investigation as we're learning more about these next generation SERDs and their efficacy in patients with different ESR1 alleles and how the polyclonal mutational burden can potentially impact therapeutic efficacy. As we saw from prior data in the Paloma-3 study, certain ESR1 alleles were associated with worse outcomes on fulvestrant, specifically the Y537S allele, which in our real-world population of patients treated with elacestrant, we did not see any differences in therapeutic efficacy based on specific ESR1 alleles, whether that was Y537S, D538G, compared to all other alleles. And that may be related to the pharmacology and pharmacokinetics of elacestrant therapy compared to prior generation selective estrogen receptor degraders, and really shows that elacestrant can be an efficacious therapeutic option for patients regardless of the specific ESR1 variant that's detected in their tumor. Now, the question of polyclonal burden is interesting, and I think an area that requires further investigation and interrogation. What we saw was that patients with high polyclonal burden, so 4 or more concurrent ESR1 mutations detected at baseline, had worse outcomes on elacestrant monotherapy, shorter time to next treatment, shorter time to treatment discontinuation compared to patients with just a single ESR1 mutation detected at baseline. And that may reflect mutational complexity within the tumors, predicting worse outcomes to these therapies. But I think it's a preliminary insight that's interesting and will require further investigation and testing in other either monotherapy or even combination therapeutic studies.
Thank you. Very, very, very well answered. Look, in the interests of time, I'll draw the session to a close. but those in the room who have other questions may be able to approach our presenters personally. Thank you again for attending this excellent session.